sleep through things, but it's good to have everyone on board and it's good to see everyone here today. My name is Sabath and I'm the director for the Boston Congress of Public Health Thought Leadership for Public Health Fellowship. It's a mouthful, I know, but it's the Thought Fellowship that we run every other year. So this is the sixth cohort, and part of what we do is to provide a platform where we have our fellows demonstrate their understanding of the thought leadership and sort of launch them into producing different podcasts to talk about their thought leadership. And one of the things we are doing this time is to have you here, listen to them, and provide concrete feedback that they could use to improve their work moving forwards within the duration of the fellowship. So we've been having different series as this one. So we've had two so far, and this is the last for this cohort. And we just want to crave your indulgence to, listen, ask question as much as you can. The chat box is always open, and we're always there to respond to your questions. So I have with me here Dr. Cersei LeCompte, who is the co-CEO in chief co-CEO of BCPH and CEO-in-chief of the Boston Congress of Public Health's Review, which is our journal that we publish our academic stuff. So it's good to have everyone here. Within the next 45, 50 minutes, we'll be hearing Dr. Paula and her guest talk about diabetes. I'm from Africa, and it's one of the things we usually suffer from the condition. So it's good to listen to this topic. So I'll pass it on to Paula, who would facilitate within the next 45 minutes. All right, Dr. Paula, you're on.
Thank you. Thank you, Sabath, and thank you, Dr. Cersei. Welcome, everyone, and thank you for joining us for the very first episode of Beyond Non-Adherence, Reframing Diabetes Care Through a Systems Lens, excuse me. I'm especially grateful that we're launching this podcast today on Juneteenth, a day that commemorates freedom while also reminding us that the pursuit of equity continues. As we reflect on that legacy today, it feels especially meaningful to begin a conversation about health equity, access to care, and very importantly, the systems that shape health outcomes in our communities. I'm your host, Dr. Paola Acevedo. I'm a primary care clinical pharmacist, a certified diabetes care and education specialist, and a diabetes advocate practicing in a federally qualified health center in Washington, D.C. Over the past decade, I've had the privilege of caring for patients living with diabetes and other chronic conditions, leading diabetes education programs, improving medication access, and working alongside some incredible interdisciplinary teams to help patients navigate an increasingly complex healthcare system. My work sits at the intersection of clinical care, public health, and health systems improvement. And through those experiences, I've noticed a recurrent pattern in how we talk about chronic disease, in particular diabetes. Patients are too often labeled as non-adherent when they struggle to take medications consistently, to attend appointments, or to meet those treatment and lifestyle goals that we're often recommending. But the longer I've spent caring for those patients and navigating our healthcare system alongside them, I'm the more I've realized that what we often call non-adherence is not that simple. Behind that loaded label are often much bigger challenges, which many of us can actually relate to. Affording medications, navigating insurance requirements, accessing healthy food and reliable transportation, understanding those complex treatment plans that our providers recommend, managing distress or burnout, or simply just trying to care for a chronic condition while balancing everything else that life demands. As a clinical pharmacist, I've had the unique opportunity to witness many of these barriers in real life, in real time, and those experiences have changed how I think about chronic disease care. So this podcast asks a very simple but important question. What if we've been framing the problem incorrectly? What if many of the outcomes that we attribute to individual behavior are actually shaped by the systems, the policies, and the environment surrounding our patients and our care teams? This conversation matters because, as many of you know, diabetes is not a small issue. I would say that it's actually one of the defining public health challenges of our time. Today, more than 40 million Americans are living with diabetes, and more than 1 in 4 don't even know they have it. Another 115 million Americans are living with prediabetes. Now, globally, an estimated 590 million adults, that's one in every 9 adults worldwide, are living with diabetes, and that number is projected to increase to more than 850 million in the next 25 years if these trends continue. That's pretty concerning. We also know that diabetes disproportionately affects historically underserved and marginalized communities. In the United States, Black and Latinx, Indigenous, and lower income populations unfortunately experience a greater burden of diabetes and often face the greatest barriers to accessing high quality medications and preventive services. Worldwide, nearly 3 out of 4 adults living with diabetes reside in low and middle income countries. Now, at the same time, we're also living in a very exciting and very remarkable era of innovation. We have continuous glucose monitors, which many of you know as CGMs, automated insulin delivery systems or insulin pumps, and medications like GLP-1s that have transformed the treatment of diabetes and chronic disease. Yet innovation means very little if patients can't access it. Too often, people are forced to choose between medications and groceries, or they may encounter insurance restrictions or other types of requirements that delay or prevent access to those very therapies that could improve or even save their lives. And the longer I've worked in healthcare, the less I've come to believe that better outcomes depend solely on better patients. More often, they actually depend on better systems. And that's the belief that inspired this podcast. My goal is to create thoughtful, honest, and human conversations that explore these challenges from multiple perspectives, not just us clinicians, which you'll hear from us today, but also patients, caregivers, advocates, policymakers, and public health leaders. This first episode is about setting the stage. I want to talk about the current landscape of diabetes, those barriers that I keep mentioning that our patients and our care teams are encountering every day, and why reframing this conversation matters if we truly want better outcomes for everyone. Now, before we get started, I'd also like to mention that today's conversation reflects our own professional experiences and personal perspectives. And our hope is that it sparks thoughtful discussion during and after this webinar. I also hope that you take away some new ways of thinking of diabetes and chronic disease care and public health. With that said, I truly couldn't think of two better guests to begin this conversation with. Today, I'm honored to be joined by my colleagues, Dr. Darlene Lawrence and nurse practitioner Barbara Dominguez, two incredibly respected clinicians, educators, and longstanding leaders in community healthcare here in Washington, D.C. I've actually had the privilege of working with them for the past 9 years. Both of our guests have spent decades caring for patients, mentoring the next generation of healthcare professionals, and also serving communities across our nation's capital. They've also witnessed firsthand how chronic disease care has evolved over the years, while also seeing the challenges that persist and continue to impact our patients and care teams today. Their experience, leadership, and connection to the community bring an invaluable perspective to this discussion, especially as we think about what equitable and patient-centered care actually looks like in practice. Now, rather than me telling everyone about your incredible careers, I'd love for our audience to hear directly from each of you. Can you tell us a little bit about your journey, the community you serve, and what has kept you committed to this work over the years? And Dr. Lawrence, let's go ahead and start with you.
Good morning. Thank you, Paola, for the brief introduction. Thank you, everyone, for coming this morning, celebrating Juneteenth, talking about a little bit about how we can have 200 and 300 more years here in a healthier state here in America. It's very important for me to celebrate today. I am a family physician, born and raised in Washington, D.C., trained at Georgetown first in public high schools and public schools, and then to Wake Forest, North Carolina for undergrad, and Georgetown here in Washington for medical school and residency. And I maintain an acting assistant professorship here at Georgetown teaching in family medicine. After residency, I decided to stay in the district and treat and help to care for my own community. So for the past 35 years or more, I have been taking care of patients here in DC, first in a private practice, and more recently for the past 16 years, I've been at Unity, where I treat patients, and I am a residency assistant, an associate professor, and associate director of the residency program that trains osteopathic family physicians to treat our community. It's a teaching health center, and it's at a federally qualified healthcare center. So I am here taking care of the public.
Thank you so much, Dr. Lawrence. Barbara?
Hello. Yes, welcome everybody. I am Barbara Dominguez. I am a family nurse practitioner. My my career path was a little windy, so I won't start with all of that. I will. Well, I'll just mention this is, I think, is a little bit funny. I started out in high school in vocational training as a cosmetologist back in the day. I know it's a very bit weird. Didn't know what to do, went to business school, didn't know what to do, didn't like that, wasn't for me. Um, Went to University of Maryland in College Park. I got a biology degree, which really sparked my interest in science, but still wasn't quite the right fit until somebody, one of my mentors, convinced me that I am indeed a nurse. So I found myself in nursing. I started my career as a surgical intensive nurse at Washington Hospital Center and very quickly realized how many of these hospital admissions could have been prevented because there was no preventive care and access to care and access to decent treatments. It was just amazing how many people ended up in the ICU. So I got myself back into school, and lo and behold, 20 plus years later, I have been a family nurse practitioner in community health and working not only with the community, but also helping to build our workforce in helping the nurse practitioners to get the training that they need and the experiences that they need. And then in addition to that, I also serve as the president of the Nurse Practitioner Association of DC currently.
Wonderful. Thank you so much, Barbara. And thank you both again, actually, for being here and for the work that you continue to do for our community. I'd like to begin by stepping back a little bit and kind of taking a look at the bigger picture before we start talking about solutions and possibilities to those barriers and challenges that I mentioned earlier. Why don't the both of you help us understand a little bit of sort of where we are today? So, Dr. Lawrence, I'd like to start with the term that, the title of my podcast, a term that almost everyone in healthcare has either used or heard. When you hear the term non-adherence, what assumptions do you think are being made about patients, and what do you think is missing from that conversation?
So that is actually very easy because anytime you start a word with a negative, so non, it gives the implication that something is wrong. And when you say non-adherence, the main presumption is that something is wrong with the patient adhering to a plan that was very thoughtfully given to them. And that is usually not the case. As a matter of fact, it is never solely the case. If there is non-adherence that goes on in chronic disease and specifically in diabetes, you can almost bet that some of this has to do with the person who is prescribing that treatment plan and how they did it and whether they communicated the plan appropriately and enough. And does it get paid for? And are the pills or different treatment too much for the patient that they prescribed for? So non-adherence currently usually is talking about the patient not doing what is prescribed. And that, for me, is the paradigm shift that needs to be changed starting today.
I love that. That's why I started this platform. Now, Barbara, what would you have to add to that?
So I 100% agree with everything that was said. It really is it's this relationship that we have to build not only with our patients, but with their families, with other care teams, with the community, because without understanding kind of where we are and the framework and the restrictions and the barriers that not only do the patients have, but we have in healthcare, it makes it very difficult to help people help themselves. And so putting the whole problem of healthcare, right? And we don't even think of it as health. We think of it as a problem that we have to fix instead of things we need to prevent, and giving people the ability to actually prevent these issues from happening in the first place.
Thank you. Thank you. Now, you've both had the opportunity to watch diabetes, chronic disease, primary care evolve over the course of your careers. I want to know what's one thing that's improved and what's one thing that surprisingly hasn't really changed during that time. Let's go ahead and start with you again, Dr. Lawrence.
You added the one thing that hasn't changed. The one thing that has improved is something that continues to improve in America and in the world, and that's knowledge. Our knowledge continues to improve over the years, over the decades. We have CGMs that are now affordable at the store, and you can just go and buy it if you have money. We have GLP-1s, which once again, you can buy, not even at the store, but on the internet, right? And
Subscription.
Yeah. I think they're called subscriptions, but so we have technology that has improved, and I think that that is so important. The internet is a interesting place to be. It's not all bad. It's not all good, but it's not all bad. And so technology has improved. What hasn't really improved is our understanding of the patient being the center of any healthcare team, the center of care, and where we need to focus before we start to spread out all of our knowledge on them.
That's a great response. Barbara, what would you have to add to that?
I feel like Dr. Lawrence is stealing all my thunder. No, I'm just
It's
kidding.
all right.
No, but there is a lot of push-pull, and as much as technology has really moved us forward, it really does create oversimplification. It offers more and more disparities in health. So, for instance, I don't know if you guys seen the rise of these like on-demand MRI sites. I actually looked up the data, and it's something like, I don't know, it was like less than like 0.4% of the time something's actually found. And even lower than that, something that's profound. So we always do these, we got to weigh it if it's worth it, if it's not, cost benefits, population versus personal, individual. And we still don't have good answers. So yes, we have a lot of data, but we don't know what to do with it. So that actually is again, it's this push-pull, right? So we have a lot of data, but what do we do with it? Is AI really going to be the answer for it? We have absolutely no idea. So we're moving forward. It feels like at a snail's pace, especially when it comes to best approaches for our patients, because we have all of these great guidelines, but is even the development of the guidelines the best way of approaching these situations? So we've got a lot of work to do, but we truly have come a long way in approaching our patient care and applying the knowledge that we do have.
I agree. I find it very promising that we have all these new technologies and these new therapies. I mean, we briefly mentioned the GLPs and kind of the game changer that has been, not only for diabetes, but all of these expanded kind of indications for it. But we have to kind of keep going back to, but can the patient access it? Because if they can't access it, then it really means nothing. We're not going to see that benefit. Now, Dr. Lawrence, from what you've seen in practice, I want to give the audience a little bit more of an idea of what these barriers that we keep mentioning, what are they? So can you go ahead and share with the audience, what have you seen in practice? What are the most common barriers that your patients are facing today?
The barriers include the social determinants of health, which for me, the number one is education. So there's varying degrees of level of education and knowledge base that patients, including clinicians, have, and how to be able to effectively use what they have learned. Then there's finance and money and lack of, or budgeting and lack of, is definitely a barrier, but in a different way, because even those who have no money can get services and resources, and those who have a lot of money can decide not to let go of their money for treatments because they had put a different value on the money they have. So it's the money and the budgeting in a big, in a small world, in a big universe. It's not all, it doesn't affect everyone the same. And then the biggest barrier that can affect, if you remove those two, is trust. Because even if a patient has a great insurance, even if a patient has graduated from college and has a master's degree, and even if a patient has money, that they have a money, even with some discretionary funds, if they don't trust what is being told to them, both in the media and in the doctor's office, both in the on the radio and sitting with their nurse practitioner, if they can't put those two together and trust the plan that's coming up for them, it's not going to happen. And so that's a big barrier as well.
And we're
I'm
actually
going to
going to
leave some for Barbara.
Yes, I was going to say we're actually going to come back to that in a little bit because I think that's a very important topic that I want to expand a little bit on. I would also add, as far as barriers, there's just a lot of competing priorities for anyone who, I mean, for all of us in general, but anyone who's a patient. Can I take the time off of work? Right? Can I contribute to an HSA card that then I can use at the pharmacy if something, is more than what I expected it to be in terms of cost? You mentioned education, health literacy, at least for the patients that I work with. So I typically get, very, very elevated A1Cs, which is a measure for those folks who are not in healthcare, a measure of someone's diabetes control, really elevated A1Cs. And oftentimes I've seen a connection where the lower the health literacy, obviously the more difficult it is to manage such a complex condition. It just requires so much. So I wanted to add a little bit to that. Now, you both touched on something. Were you all trying to say something? Go ahead, Barbara.
I
Yeah.
was going to say, yeah. So part of that health literacy too is understanding, or the patient's understanding of how to navigate that healthcare system,
Yes.
which as
Yes.
a provider, I am 100% part of this problem because I don't always know or realize or have the time or patience, whatever else it is, to actually help guide that patient through that resource, because you assume patients know how to use the pharmacy.
Mm.
And I'm telling you, they don't always know. Or, you call the pharmacy, they don't answer. And then when you finally, literally after hours of being on the phone, I am 100%, 100% serious about that. And I'm sure all of you have had that experience. After being on the phone and you finally get to talk to somebody and all they can say is, I don't know. I don't know
Mm-hmm.
why it's not
Blank.
covered or not
Mm-hmm.
being refilled, or
Mm-hmm.
and then you go through this whole cycle of trying to figure out what's going on. It takes an amount of Herculean effort oftentimes to get people what they need. So it's really crazy what all we have to do to get people what they need.
100% agree. And I can even speak from personal experience a couple years ago, just struggling as a healthcare provider, struggling to navigate the health system that I work in. And I'm like, if I'm struggling, then, what is going on with my patient who may not have, health literacy or whatever the case may be. So it's a big problem. Now, you both touched on something that's very important, and that's that these barriers aren't typically medical or clinical. I think those things we can typically figure out in the room. That's what we trained for. But most of these barriers stem from the way that the healthcare system is actually designed, as you were saying, Barbara. So I'd like to spend a little bit more time on that. Barbara, what is your perspective on, well, let me say this. I think a lot of the clinicians in the room are gonna relate to this because it's something that they probably experience daily. Okay, so bring us into an exam room. How often do treatment decisions reflect what you actually feel is clinically appropriate or clinically best for that patient versus what the insurance will actually pay for or cover?
Right. So my, I'm going to put in quotes, specialty is hypertension. So I manage many, many, many patients with hypertension along with my colleagues. So oftentimes they'll come in haven't been seen for 2 years. I'm going to give an example. A 45-year-old been out of care because I've basically been healthy. I feel well. I haven't had any issues, but it's been a while since I've been seen. So I'm coming in for my physical and has a blood pressure of 153/86. I'm sure Dr. Lawrence can attest to these patients we see on a regular basis. And so we have the conversation. This is high blood pressure. These are the treatment options. These are the lifestyle changes that will help to improve your blood pressure. Then the patient will often say, but I want to treat it naturally. So we have that conversation and how we're trying to decrease the progression of the disease itself so that they don't end up with kidney problems, with vision problems, with vascular issues. Mm-hmm. And so then inevitably we'll have the conversation about blood pressure medications. And so the treatment guidelines actually have a preference for step 1 therapy as combination therapy. So yes, they are on formulary, but most formularies for the insurance companies have the combination medications as step therapy, meaning you have to start one and then you have to add. And then if they're still not at goal or whatever the other case may be, well, compliance, right? We're throwing that word out again, trying to make it easier for the patients to take their 20 medications and not adding on more. This is our third visit now. And then they're maybe still not at goal. So then we have to have them come back again. So on average, I've seen data anywhere from 3 to 10 visits before that particular patient has a blood pressure that is considered controlled. Now, not to mention all of the paperwork that you have to sign or get approval from the insurance companies, or trying to get your patient to see a cardiologist in the next month, if we're lucky, because we're all backed up. And even, as a primary care provider, trying to get my own patients back in a week, I mean, I might be booked out for 3 months. And so how to make those accommodations? Yes, we do have other care team members that can help us, but it feels like everybody's just stretched as thin as we are. So trying to accommodate as much as possible without, pulling your hair out or having other systems break down in the meantime.
Yeah. And so it's interesting. It sounds like the guidelines are recommending for us to start with combination tablets, right? Which makes it a little easier. What that means for folks in the audience, again, who are not in healthcare every day, is that one tablet can contain 2 to 3 medications that can basically reduce that blood pressure and get us to that ideal blood pressure sooner rather than later. Let me say that, so that we can avoid those complications that Barbara mentioned. But unfortunately, the way that it is now is that you have to try some individual tablets one by one, oftentimes for 3 months at a time, sometimes longer, before you could even get that combination tablet approved. And that's concerning, because in those 3 to 10 visits now, what is the kidney damage that has occurred in that time frame, right? And those visits aren't happening weekly, like you said, they're every 3 months. So now we've had maybe 4 visits this year. What have we done with that blood pressure? Where's your kidney function? What has happened to your vision? Have you had a heart attack? I mean, it takes a while to get to that ideal treatment, which the guidelines say is what we should start with. So it's a huge discrepancy there. Thank you, Barbara. Now, I can't wait for you to answer this one, Dr. Lawrence. We know how challenging it is to coordinate care across the different parts of healthcare. That's what we're kind of mentioning is our struggle right now. Dr. Lawrence, what does fragmented care actually look like from the perspective of a primary care clinician? And then what are the implications for a patient navigating that fragmented system?
What does fragmented care look like for me?
Mm-hmm.
Making clinical decisions, making evidence-based medicine decisions, talking about it with my patient, and then having it stop there. That is the puzzle being broken. That is the mirror being cracked. Because when you look in that picture and you've developed the trust with your patient, you've talked with them about side effects, you've talked with them, you've had motivational interviewing, you've talked with them about what this is going to do for you. Is this something that you want? Are you concerned about your health and do you want to make changes? And we are getting on the same page. And then my care coordinator or my medical assistant sends me a nice little message in my EMR that says, oh, you need a prior authorization. Am I not the prior authorization?
Right.
Did I not have the training and choose the correct medicine? Or is the prior authorization decision being made by a person who wears a suit to work every day in a corporate office? Yes, the second one. They are making the decisions after they are asking us to take care of the patients. So that seems very fragmented for me, and it ends up being fragmented for the patient because the patient then says, Dr. Lawrence, I didn't get my medicine. Did you call it in? Of course I called it in. I did it right then. But, so whenever you have to say but, it cancels out everything you've said before.
Exactly.
So the but cancels out that I'm taking care of you. It's but. Another place says that they have to take care of you in the way that they want. And that's the fragmentation.
And then we risk losing that patient.
Your trust
that
is
you
broken.
spent, right, that you
Yes.
spent so long to get them on board. And, not the word convince, but to just educate on the importance of this. And they're like, okay, I think I'm ready for it. And then
it doesn't happen.
And then it doesn't happen.
Or as Barbara says, it takes 10 months to see a result because you have to follow these rules and guidelines that were made up by someone when you know it's time for us to do the next thing. If it took 10 months to get someone's thyroid under control, they would be in a crisis. We know that we need to increase their medicine at a certain pace. Why do we have to go back to the insurance company and ask for authorization to do the next dose? That's the fragmentation. So that's the most kind word that I feel we can use today is fragmented. Fragmented.
We'll keep it at that.
Yes.
But what else I think is important to mention here is the fragmentation amongst specialists and primary care in general. The fact that we, at least nowadays, because it's become increasingly difficult to communicate with our colleagues, our specialists. Can you speak a little bit more on that? Like, let's say you referred your patient to the endocrinologist or the cardiologist. Let's talk a little bit about that.
So this is something where I feel my time in DC and having trained in DC and practice in DC in the same communities has been very helpful, and it can be not as comfortable for someone who's moving to a new place or who is graduating from their training and starting practice in a new place. They're going back home. They came to the big city and now they're going back home to cure their community. Well, you don't know any of the specialists. And so a lot of times people, and even in training, this is something that I've taught all my greater than 150 trainees over my years, that you have to refer to someone you know. You don't just refer to a big system, because when you refer to X hospital system or Y superpower, you don't know where your referral is going. Please refer to a name, build relationships, ask for those reports back. Thank them when you get the report back. It just takes a quick little tidbit back, or even telling your patient the next follow-up you have with them, thank them for sending the report. I got it before you came for your follow-up visit. This is the way we build community. We build trust with the patient. Patients like to talk about us when they go to the specialist. They like to say, I have a doctor, nurse, I have a clinician, I have a provider. I don't use that term. My students know that. But they want to say that, and they want to know that, they want to feel like they have someone on their team. They have someone in their backpack that's going with them to the specialist visit, and that's they need to do the right thing because we're going to hear about it. So if the specialist did not send a report, You're going to hear about it from Dr. Lawrence. I'm going to call the office and say, I need it. She's sitting right here. And it's a little embarrassing to not send it. So specialists on the line, send the report. It's how you got paid. It's your due back to us. Continue that trust, continue that relationship. That's a way to sort of seal up some of those fragments that are in care.
Mm-hmm. And there y'all have it, a call to action from Dr. Lawrence. Send those reports back, please. Now, we've touched on the logistical barriers, the prioritizations from the insurance plan or the step therapy, the fragmentation in the system. But there's another very important element that we haven't really talked about, and that's our relationships with our patients. So, Barbara, what role does trust and the patient-provider relationship play in shaping their outcomes?
This is so multifaceted, and I think Dr. Lawrence did a great job of how the system can undermine our relationship with our patients when
Mhm.
we're working behind the scenes that nobody ever sees, and then that patient only gets the feeling that we don't respond, we're not checking, we're not getting the reports, we're not doing our job.
Mhm.
And so it can be very disheartening that that time it took, because all it takes is one bad interaction with a patient and they have lost complete trust in you.
Right.
It is absolutely amazing how long I have seen some of my patients, and that one bad interaction, or they couldn't get an appointment, or whatever else the case may be, can really erode that relationship. And so I actually think about it um, in a couple of different ways. And I had this one patient I had seen at various times, but he had came in for a cold and was absolutely livid that I would not prescribe antibiotics. Just
Mm.
beside himself. I cannot believe you will not give me antibiotics. So fine, he got better. Next time I saw him, for whatever reason it was not related to his cold. He actually told me he thought I was a quack because I could not, I would not prescribe him antibiotics. So we spent some time talking about what the research shows and how antibiotics do not kill viruses. And so
Mm.
after that, I could tell his demeanor had changed with his interaction with me. But it's very funny because it's from the patient side, but it's also from the provider side. And to this day, I am absolutely floored when I hear providers, thank you, Dr. Lawrence, providers, that the providers will say, my patient didn't do what I told him to do.
Mm.
They're not listening to me.
Mm.
They're not obeying what I want them to do. This was my prescription and they failed. So this like long history of paternalistic prescription, do what I say, I know better. And I've
Compliance.
actually had patients say that, well, I'll do whatever you say. Like, this is not how this works. This is your health. I
Right.
am here to give you advice. I'm here to guide, but you get to make the decisions. And so it is absolutely crazy to me. And so we kind of go back to this whole situation of this conversation of being not adherent because you didn't do what I told you to do. And it is just so embedded from history moving forward. And of course, there's other factors involved. There's, you know, financial, class, economics, race. I mean, it just goes beyond the pale for what that relationship can be. And so that trust factor, and even, the media is playing a huge role in
Mm.
this. I
Yeah.
mean, how the media really harps on all the bad things that we do in healthcare, but what about all the good things we do? Because that's not a story. That's not sexy.
Right.
How you can buy all these supplements and, lose weight and be fabulous and all the stuff, but there's no research to show that that works. But why won't you give that to me?
Mm-hmm. Mm-hmm. So we're
That,
battling a lot as clinicians.
yeah,
It sounds
it's
like
it's amazing, but that trust factor is huge.
very, very important. Excuse me. Now, I want to come back to something that you actually both mentioned, which is the care team. And when we often talk about like diabetes, primary care, many people often kind of just picture the patient and their primary care physician or their primary care provider. Dr. Lawrence, for those who don't work in healthcare every day, can you just tell us a little bit about who else makes up the care team and sort of what is each of their roles or why are they important to the team?
Do you want the Campbell's soup version? You know, potatoes, tomatoes, carrots, and peas. Okay, there's so many members that are on that care team. Let's start with the patient.
Number one.
Absolutely must identify them and let them know you are the captain of this team.
Mhm.
We are all here to support you. Then you have
I love that.
the person who checks them in at the front desk. They will not get back to see me without going through the person who checks them in at the front desk. They have lots of different names, patient representative, check-in, registration clerk, but they are really important because they check the insurance. So yes, the insurance company is a member of the healthcare team. The nurse, anytime you work in a big practice, you have to have an actual nurse, not someone who's acting like a nurse, but you have to have a nurse. They are licensed. They can do lots of things. They can give medications, they can give injections, they can do education for your patient and on their disease process, and they are definitely a member of the team for the patient. Then you have your medical assistants when you have more money. If you're in private practice, you may only have one of these. They may be your front desk, your nurse, your medical
Everything.
assistant, your registration, your security. They may carry a big stick. But in the bigger the system is, the more of these that you can have as separate roles. And we want everyone to work up to their license. Everyone should work up to their training. So you have your medical assistants who do more of the triaging in the room, like taking the vitals, checking the history, asking about their mental health status that day and their mental health status over the previous 2 weeks, giving injections that are not that they're able to give. They can't give certain ones, but they can give others. They can give immunizations. They can help check the medication history and make sure that it's up to date. So, and talk with the patient about it. It looks like you haven't had a refill on this med in 6 months, but this medication was only given to you for 2 months. What's the problem? So they can get a lot of the history for you. Then you have your health educators. You have your clinical pharmacists. Your clinical pharmacist. Anytime your practice is big enough for you to have a clinical pharmacist, you can like really hit your lapel and say, we are doing something, because they can really help to direct a patient's care from the pharmaceutical standing and looking at a lot of the other things that are going on in their practice. You have directors, you have physical therapists, you have health educators, you have folks who are on outreach, especially for patients who are on medication assisted treatment and are dealing with addictions. Your outreach specialists are so important to keep an eye on them. Social workers, all federally qualified healthcare centers have to have social workers. They help to navigate those social determinants of health for the patient, including food insecurities, insurance, products that they need for home care and medications, making sure that they have the secondary insurances, especially for patients who have Medicare. They have secondary insurances to cover their office visits and their medications and their durable medical goods. Can I go on? Have we made it to the peas? Because
right,
we
we made
leave
it
the
to Z
peas
yet.
out of my soup, but we probably have peas in there as well.
The only thing I'll say is if you're real fancy, you might have a dietitian, which is even
Yes,
more
the
important
dietitian and
nowadays.
nutritionist. Yes. Exercise therapists.
Yes.
Food pharmacy. We are so lucky to have food pharmacies where the three of us work together. Wow. I mean, we're getting into luxury car now, Mercedes, right?
I love that. Thank you so much, Dr. Lawrence. I hope the audience understands a little bit more of that team aspect now. Um, as we start to kind of wrap up in the next 15 minutes or so, I want to shift the conversation because we've talked a lot about kind of what's broken, what are we dealing with. I want to end it by talking about what do we see that's possible? Where could we take this? So this question is actually for the both of you. As you think about the future of chronic disease and diabetes care, primary care, What changes do you believe are necessary to create a system that better supports our patients as well as our care teams in actually getting that or delivering that equitable care? And I'll start with you, Dr. Lawrence.
What do I see? Let's take a vision trip, which is something that I do with my residents every year. We talk about the perfect team, and then we talk about what would be their team when they're in their practice. And what I think we need to do is shift our thought process in no longer looking at the patient as a demon in this situation of disease. Mm-hmm. They are not a demon of disease. They are a victim of disease. And it is our jobs to help them navigate and get through the disease onto the other side to a state of health, not just a state of cured. So as we work in advocacy in our towns and in our country, we want to talk about having a shift in from the politicians and the folks who call themselves activists to look at the patient as needing help to be in health, not just to treat disease where it can make pharmaceutical companies a lot of money. If CGMs help the majority of people who are navigating through diabetes, then let's get CGMs for everybody, and you don't need a prior authorization. You've been told by your clinician that you have diabetes, bam, you need a CGM so that we can see what to do next. What about if we did that before we gave any medicine? What about when the hemoglobin A1C is elevated? You need a CGM because that was a point in time. I need to look at you for the next 3 months and see what's going on while you start walking and stop smoking. So let's do more for them and not demonize them and not try to godify us because half of us have diabetes too. What did you say in the world? 1 in 9. So there's a lot of clinicians. We're dealing with diabetes as well. And so let's do this together as a team. Let's take every person who has stock in this and get a little bit of investment, not just stock, but actual investment in the process. And that's what I hope that my folks who have come through residency, my students who have come through, my colleagues who still come to my desk and say, what do I do with this patient who's blah, 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 and I can't get a prior auth for their GLP-1, so can I give them something else and blah, blah, blah. Yes, we can do more.
Yes, mic drop. Go ahead, Barbara. I would love to hear your perspective on this too.
So, I suppose we all work in community health because we have similar values and thought processes. So yes, investment is huge. And I think from my perspective, what I would love to see is some kind of national health care. Like everybody needs access to care. And we're chasing our tails if we don't believe that only people who can afford to have care should get care. Because we're missing a whole lot of people and that's what's driving our cost. We're treating problems, not preventing the problems. But to me, it's actually more than just national health care and whatever that looks like. I mean, there's a lot of very smart people, much smarter than me, who have been working on this their entire lives, and we're still nowhere nearer than we were. Well, that's not true, but you understand what I mean. But I think honestly, taking that one layer off of, say, national health care, I think really what it comes more like a little bit further down is improving our national health care and public health infrastructure. Because without that, we can throw all the money at insurance and still not solve the problem. So if we're not investing in vaccines, if we're not investing in education of our providers, there's so much to the infrastructure that if we're missing that key component, we're still going to struggle.
Mm-hmm. And not to mention that I think something this probably could take several episodes in the future, but healthcare is a business in America. I mean, that's probably problem number one right there. Exactly, profits. And so you made a great point that prevention is so important, but we're missing the mark on that. And I have a feeling it ties back to healthcare as a business in America. So, but like I said, that's probably some future episodes there. So
Prevention is not sexy.
prevention is not sexy. Yeah. It's not fun. All right. So before we transition to audience questions, I want to get two more things out of y'all here. Number one, what advice would you give to younger clinicians and public health professionals, Dr. Lawrence?
Get to know your community inside and out, up and down. Know your community and become an integral member of that community. It may mean reaching out with a card at a holiday time, or even just a text saying, Ramadan Mubarak to someone, so that they know that was very nice. They remember me, or they know who I am. So get to know your community.
Beautiful. Barbara?
Advice: keep learning. The amount of information we need to know is endless, but even more so, show up at the table. If we don't hear voices from all angles, all perspectives, all nations and races and socioeconomic classes and whatever it may be, everybody needs to be heard and hopefully understood and valued. Without that, people will make the decisions for you. And as they say, if you're not at the table, you're on the menu.
You're on the menu. One of my mentors says that very often. It took me a minute to understand that, but boy, oh boy, when I understood, I was like taken aback. Very important. Thank you both. That's lovely advice. Now, last but not least, before we transition to audience questions, I'd like to leave both of you and our audience actually with something else to reflect on here. And I actually would like for you to answer this. If diabetes is one of our nation's, or even, one of the globe's biggest public health challenges, as I mentioned earlier in my introduction, why do you think so much of that responsibility is still placed on the individual patient? And I would love for the audience to answer some of this too. But Dr. Lawrence, you go first.
When the responsibility is placed on the patient, then the prescribers and the clinical system, the system can take back and say, it's not our fault.
Not our fault.
And that is something that's been set up for generations. When there was syphilis, before there was penicillin, it's not our fault. We're doing everything we can. We're putting poultices on these wounds. We don't know why these ulcers, what's wrong? They don't even hurt. Yeah, but it's syphilis because it's not our fault. We have to take the blame. We have to say, it's our fault. What can we do?
I think the system itself
has
to
to
take that
say that.
responsibility.
And the system is not a person. And so it's so easy for the system to not take the blame, because who is the system? Let's think about that today.
That's a great question. Who is the
Ruby
system?
Bridges, who
Oh,
is the system?
I love your shirt. Perfect. Barbara, what do you have to say?
So, it's really an American value, I think, that we have to pull ourselves up from our bootstraps. You're making these choices, which, yes, that is part of it, but it is not totally, again, one person either succeeding or failure. And that's not how health works. It's not on or off. It's not yes or no. It's not you're healthy or you're unhealthy. It's this full spectrum.
Mm-hmm.
And because we do have the ability to really define what health means for us and how we can contribute, but we also need that help. We need that guidance. We need the systems to help us to achieve what we need. So why are we still blaming people? Yes, it's easier. Yes, it's built into our system. Um, yes, there's a lot of structural issues. So having to reframe it and having these conversations is huge because I mean, we all say it too, like, oh my God, that was a terrible conversation I just had or interaction I had with that patient. They didn't understand what I was saying. Well, maybe I didn't change what I was saying. Maybe I didn't contribute in a meaningful way to that conversation. So picking up on these clues and these issues and working together is going to be key.
You both said it so beautifully. Thank you so much for all those jewels, all the tidbits. Thank you again. And we're actually going to open it now for Q&A. Dr. Cersei is going to guide us through some of the questions that came through the Q&A or even through the chat. So let's take the last few minutes to do that. And then I want to close us out.
Hello, everyone. Now, what an amazing discussion that we got to witness today. There's been a lot of engagement in the chat, and I just wanted to share with you some of the comments. Folks wrote that they thanked you for today's session. Someone also was sharing ideas, sharing their experience as someone who is not necessarily a specialist in diabetes, but decided last week, before they even knew about the seminar series, that they wanted to become a specialist because it impacts the patients that they're going to be working with on so many levels across the lifespan. And a lot of folks, saying, well said, Dr. Lawrence, absolutely. And then also folks exchanging ideas and agreeing with one another. One quick aside, we don't offer CEUs, but we will be providing those who participate today with certificates of participation. But one of the sort of concrete questions that came up was, in terms of garnering trust, didn't know if you had specific trainings or approaches that you would recommend to a clinic or a community-based organization, aid service organization that may be encountering patients who need greater support and otherwise have been labeled as non-adherent.
Dr. Lawrence, Barbara, either of you would like to take that?
Everyone should hire Paola Acevedo. And did you get the spelling right? Acevedo. And then you should also have your teams practice motivational interviewing. It is something that is available just online, and then you can practice that. Maybe quarterly, maybe every twice a year or every year, but practice with your teams. As often as your teams change, you want everyone on the team to understand motivational interviewing.
Absolutely. Anything to add, Barbara?
Yeah, so there's a lot of different techniques. Motivational interviewing is a huge one and super helpful. Trauma-informed care also, because you never know what you're walking into. Sure, they're coming in for stomach pain, but a lot of the times that's not the issue. Or oh, by the way, now we're getting into the actual issues of why you're coming to see us, and why you're asking for help. Sometimes people come in and they say, I don't know why I'm here. Those are the ones you need to listen to. So lots of resources. I'm sure we can come up with a list if people really want a list of links and websites and resources. Absolutely. But those two for sure.
I agree. And just to take it away from like tools and trainings, I honestly just sit down with people and have a conversation. I'm not,
Mhm.
I mean, yes, I introduce myself, I'm a pharmacist, so on and so forth, but I'm just having a conversation with another human being. And I think that lets the guard down immediately because now we can share things that you probably wouldn't share before, right? I can talk about things that I didn't get to talk to my primary care provider, not only because the visit was quick, but because I didn't quite feel so comfortable. So just practice letting your guard down so that the person you are working with, having a conversation with, also lets that guard down. And now we could just have a what were you calling it, Barbara? A push and pull, just like a natural conversation built on that trust. So that's honestly where I would say to start is just have a conversation with another human being. They're not your patient; they're another human being.
Um, I think that raises an issue. You brought this up during the during your discussion about how, you know, there's payers involved. It This is very much a business. And someone actually shared in the chat, as a
Mm,
psychiatrist, I personally think a lot of the problem is that we are the so-called developed country that has a healthcare industry,
industry. Mm-hmm.
rather
Mm-hmm.
than, ensuring folks have access to care. And
Exactly.
I guess, in terms of questions around that, um, just thinking about the complexity, you were talking about fragmented care. And I was thinking, like, what is the impact of like comorbid conditions on client engagement and care? You talked a lot about medications. Someone else pointed out, nutrition is an issue as well. Um, what what does something like comorbidities, how does that impact or exacerbate? Like, what can we do to eliminate this need for what Barbara called this Herculean effort to deliver care and make sure folks have optimal health outcomes?
I think that's a huge one.
That's a big, just
That's a big
a
one,
little light
right?
questions as we wrap up.
As we wrap up, right? Probably above all of our pay grades, but I would say, from my perspective, it comes back to prevention, right? So let's kind of talk about diabetes because, of course, that's my specialty. When you have diabetes, you eventually will likely develop high blood pressure, right? Cardiovascular disease, some sort of neuropathy or nerve damage, visual issues, kidney issues. I mean, it becomes a sort of sequela, a snowball effect of these other sort of conditions that if we don't treat it quickly enough or soon enough, that's when we start to develop these issues. So it goes back to Barbara's point where we see what the first line treatment is. This is what we recommend as where you start. But oftentimes we are not able to start there at step one. We have to start somewhere else because, as Dr. Lawrence mentioned, an insurance company, a payer, is wanting to guide the care their way, right? And that
Mhm.
can usually lead to the delays that unfortunately lead to those comorbidities. Comorbidities, for those folks who are, again, not in healthcare, it just means that apart from having that one condition, you have other things that are now comorbid with that primary condition. So that's what I would say. It kind of boils down to, can we prevent it in the first place? And how quickly can we treat that person's glucose levels? How quickly can we normalize it to prevent this sort of and then, and then, and then? Anything to add from you all? No.
Which means education.
Lots
The,
of
your
education. Oh,
patients need to know that this is one piece of what's happening with them. And they all, they'll come and say, "What's wrong with me?"
mm,
Well, where do you want me to start? Do you
right.
want me to start at the beginning or do you want me to start where you are now? Because at the beginning was when you were 9 and instead of dinner, you snuck potato chips
Mm-hmm.
on a continuous basis,
Right.
not one bag of potato chips. So let's talk about that. And does that mean we need to get to psych? Does it mean we need to get to counseling? And let's talk about where some of this came from. So as we're working on
Mm, mm,
prevention of progression,
mm,
they can have a greater understanding of what happened to them. What's happening to me?
mm-hmm. Because it didn't just
Yeah.
happen
It didn't
today.
just happen
It's
today.
been happening for the past 30 years,
Right.
basically. And I love the point you made, at 9 years old, and that education, so that education needs to start way sooner. That
Yes.
needs to start, whatever health class is, needs to
Yes.
be something completely different for our little kiddos
Yeah.
and in high school and so on and so forth. It needs to start very early because the disease begins then, and
Yeah.
it just manifests later on in life.
So I'm going to throw out to not just where we start, but um, the care management and the case management is
Mm,
super, super, super important when it comes to people with multiple complex issues.
mm,
We see patients with dialysis cancer. That's a huge one. And then trying to manage your diabetes and your neuropathy now, and now you have heart problems. It's just a huge cascade. And having one person alone trying to manage their life. I tell my patients all the time, like, they have, a stack of referrals and all these specialists they need to go to. That's a full-time job.
absolutely.
Who has time for that? And then to understand when you're not, medically trained, it's very overwhelming. And many times people give up because it's a hard system to navigate.
I agree with that. I
Mm.
agree with that, Barbara. I don't know if we have any time for more questions,
We
Dr.
we
Cersei. I don't think we
actually
do.
we're actually officially in the after party
Yes, we're in the
at
after
this
party.
point, but this is wonderful. And we do have one final question that came in,
I
and it's quite
love
good.
that.
So if you can give like 2 more minutes to answer that, um, you know, so the official webinar is over. We're in the after party. And if you have a moment to answer one last question, that would be
We'll
great. And
take
then
it.
okay. So um, Christina Fraser writes that, hey, this has been great. I'm a teacher. From an educator's perspective, what role can classroom teachers play in diabetes prevention and education? How can we teach healthy habits in a way that's evidence-based, age-appropriate, and avoids stigma and blame?
That question makes me want to cry a little bit. And I want to give Barbara and Dr. Lawrence a chance, but something that I kind of been trying to even teach in my own family with my nieces and nephews, my sisters-in-law and whatnot. A lot of it has to do with the food, right? So what we call snacks, the cookies and the chips and the, Oreo this and the juice boxes and all that stuff. It's starting from there, unfortunately. And I feel that this kind of brings up even a larger sort of issue or topic of how can because Christina, as a teacher, this doesn't fall solely on you. What can the education system do, right, to provide the best snacks for the population, right, for the children, which is going to involve much less processed foods, right? It's going to involve whole foods like fresh fruits, right, fresh veggies, maybe certain dairy products like low fat yogurt and so on and so forth. But so I would say it starts with educating on that those things are not snacks. They're just processed junk, and I hate to call it that, but that's what it is. And helping them understand that it starts then, helping parents understand again that all of these issues that we're dealing with in our 30s, 40s, and up, it started in our youth, right? Being exposed to all of these sort of processed things. And then the other thing I would say is leading by example, right? And I think because I know Christina personally, I think that's something that you do beautifully. You are someone that works out, you engage in physical activity, you are someone that has been committed to your health. And I think demonstrating that to the kiddos, leading by example, I think is very powerful because let me tell you, some of the best people or some of the people that I've looked up to the most have been my teachers. And so I feel that if they see you participating in certain healthy habits, that's going to motivate them to also sort of model that behavior. And that's kind of where I'll pause because I'm going to get emotional. Dr. Lawrence, Barbara.
There's a program called We Can, and I have changed it to We Will. We Can is based for kids, and We Will is for adults because we can do better. We can eat good food,
Mhm.
give physical activity, follow good habits, don't take up bad habits, and
Mm,
it will make us healthier. I teach we will to my adults because they already know they can, because they learned that they can, and now they have to decide that they will, because parents
mhm.
decide for kids what's going to be in the house, what's going to be in the
Right.
refrigerator and on the counter.
Mhm.
Parents decide whether the kids have to participate in 3 sports a year. hint, hint, my kid who can hear me, every year, 3 sports that they had to participate in. If you're not in an organized sport, then you have to do personal workout and walk. But kids don't need pedometers anymore because they all have mobile phones. They have the pedometers in them. Yes, they should be walking. They should be physically active. They should not take up bad habits like tobacco and alcohol, which means they shouldn't see their parents doing those behaviors of alcohol and tobacco. And they need to eat good food. For the school systems, for the teachers, we can programs that are based and can be introduced in the schools for an hour a week, just an hour a week, are great. And we can, once again, is available on the net, but also helping your schools to make good choices for what's available for the kids. Recess should have activity, not on the phone. Recess, put the phones up and get outside. Let's play ball. There should be these snacks or things that are available for kids to eat in the vending machines at the high school level. If you put fruit and boiled eggs in the vending machines, it will disappear. You will be amazed. If you put fruit in the vending machines, it goes away and it's not put in the trash. If you give fruits on the tray, they get thrown away. But when someone spends the money and they're hungry and that's their choice, they take a fruit. So let's change what goes on the tray. Make sure you have a box for the kids to put their milk in the box or their fruit in the box so that they don't throw it away. And then use that to fill the vending machines. Oh, we make money all the way around. So what we have to help direct the choices for the kids.
Exactly.
And then they will make good choices. We have to give them good choices to make.
To make good choices. Yes. I love that response.
So it's really true. It's the paradigm shift, right? How we frame it. Because like restaurants don't need a kid's menu, right? Kids' food is not a hot dog, a hamburger, pizza, and chicken nuggets.
Oh my gosh. Yeah.
And with French fries, right? They deserve better than that. So yes, 100% to everything that everybody has said, doing it at the, personal level in your own home, in the classroom. Even if, it's a rainy day, you get the kids up and they do 1 minute of running around being a crazy person because they've been locked up all day and sitting all day and, whatever else, because we have so much we have to fit into the day. 1 minute every couple of hours is truly helpful. But then moving it along to the county level, talking to the school board about what we're doing to these kids, and then taking it higher up to the USDA. What constitutes a school lunch, and really, do we have to feed kids for less than $2? I mean, who can eat on $2? It's amazing. Anyway, so yes to everything that was said. I love it. And again, if you need more resources, I'm sure the three of us could come up with a huge resource list.
Yes. Now, I guess I'll wrap us up. Oh, go ahead, Barbara. That's fine. Go ahead. You're on mute, though.
I forgot to mention the salad gardens. Lots of schools have these. Yes, lots of school gardens. There's lots of advocacy groups. Real Food for Kids, I believe, is one of them, who helps to advocate for healthier classroom food. I'm sure there's exercise resources, but there was one more that I heard about that I thought was really, really, really awesome. That's tangential, but I think it's really appropriate. It's called, I can't remember, but it has to do with trout. So the kids raise, right? I heard it on NPR. So they raise the trout from the egg.
The trout farms, yes.
Yes, and then they release it into the wild.
Yes.
But it shows you like the environmental impact of what we do and how that can affect our environment. I think it's awesome. Anyway.
Yes. And Casey trees.
Lots of good tidbits. Thank you for that question, Christina. That was lovely. Now, I do want to wrap us up, but before I close out the conversation, let's just kind of reflect on some of the tidbits that we did hear from both Dr. Lawrence and Barbara today. So first, diabetes outcomes are not just shaped by individual choices. I think we've hammered that quite a lot today. It's affected by or shaped by the systems that surround our patients, right? The term non-adherence is an oversimplification of what's actually going on with people managing chronic diseases. I mean, we've heard the different layers of challenges that present themselves, and also you've already experienced them yourselves navigating the health system as well. And then last but not least, creating that meaningful change requires more than just new medications, GLP-1 technology, this or that. It requires a complete shift of the system, of a complete shift of the paradigm of our mindset. It requires empathy and collaboration and actually building a system that's more coordinated, more accessible, that actually works for humans, right? So as we close today's conversation on this lovely holiday, I'm reminded that progress begins by challenging the status quo and working together to actually build those systems. I want to sincerely thank Dr. Lawrence and Barbara today for sharing their wisdom, their experience, and of course, their commitment to this community here in Washington, D.C. And I'd also want to thank the Boston Congress of Public Health, Dr. Searcy, Dr. Carpenter, Sabath, for the opportunity to actually launch this podcast through the Thought Leadership Fellowship and for creating this platform where we could actually have these types of conversations. Thank you to the audience for being so engaging. I am so excited to continue to continue the discussion. And thank you again for joining us for the premiere of Beyond Non-Adherence. I just want to kind of give you a little bit of an idea of what you're going to see coming next. I'm going to continue exploring the topic of diabetes, but eventually I will dive into other chronic conditions. And I want to bring in other perspectives. I want to bring in the voices of patients. So hit me up if you're a patient and you want to get on here and talk about your story. I want to hear from advocates, policymakers, public health professionals, students, and even other leaders that are working to transform healthcare. So thank you again. And until next time, let's continue moving beyond the blame and towards better systems. I really appreciate you both. Thank you. And thanks for staying for the after party. This was awesome.
Happy Juneteenth.
Happy Juneteenth, everyone.
Yes, thank you so much. This ends our webinar for today. Thank you to our panel. If you want more information, please visit us at bcph.org. And if you have any questions, communications@bcph.org. And if you want to connect with Dr. Piolo, we will help make that happen as appropriate. So thank you.
Yes. Take care, y'all.
Thank you. I'm just shutting down everything.